Okay, folks, I'm going to start this one over. I've tried to record it several times, but we're going to start with rheumatic heart disease. I'm going to start you with a story. It's a very, to me, interesting story, heart-touching story. So enjoy this video, and then we'll come back to the lecture part.
Well, 2 days before school holiday, Tienda started complaining about hips aching, hurting that night, and I thought it was nothing because the next day she'll just get up and play around, and I thought she was just trying to get off of school.
So we know across the board Aboriginal people have much poorer health status than other Australians. This manifests itself in a whole range of conditions and inequalities that we focus on. One of the diseases that Aboriginal people almost exclusively suffer in this country, in modern contemporary Australia, is rheumatic heart disease.
When the school holiday started, she started complaining more at night, and then one morning she woke up and she couldn't walk, and so I took her to the doctors. Then the doctor sent us to Port Lincoln for x-rays. I had to book another doctor. Went in seeing the other doctor, and they said the x-ray, there was nothing wrong with her. So we just went back home, thought nothing was wrong with her, and then a couple of weeks after, Tienda was getting more paler. So I took Tienda back to the hospital, to the doctors, and then the doctor said that there was something wrong with Tienda's heart. I'd seen her heart on the x-ray, and I knew it wasn't normal for a kid to have a big heart like that there, and then I knew something was really wrong. So when they flew a Adelaide, I knew something was really, really wrong.
Rheumatic heart disease is largely a consequence of multiple bouts of infections with group A streptococcus, which is a bacteria that can get into your upper airways, your nose and your throat. And if you have repeated or recurrent events that don't get treated with antibiotics, you can be cumulative damage on the heart, particularly the heart valves, which are, like in any pump, control the flow of blood around the body. If the valve doesn't work, the heart can leak and blood goes the wrong way.
It shouldn't be only doctors that knows about murmurs on the heart. It should be that the workers too, like the Aboriginal workers, health workers, they should all know about it too, because sometimes there's not even doctors at Aboriginal health. It just made me upset that it took me 3 doctors when the first doctor should have knew and probably wouldn't have left that surgery.
One of the important parts of dealing with rheumatic heart disease is to stop these recurrent infections in the throat from causing long-term damage to the heart. The best thing we can do is identify it early and treat it. Group A strep that's in somebody's throat, you can treat with antibiotics very readily. So making sure that you are thinking rheumatic fever, managing that appropriately is a really good way of preventing further development of disease. If somebody develops rheumatic fever, so therefore they have the consequences of the infection, those children need to go on long-term therapy with what we would call prophylactic antibiotics, or antibiotics that stop the acquisition of the bug to cause more damage. It's a very simple intervention. It's a needle once a month or once every 4 weeks. And then the last area we focus on is, once people have damage to their heart, how do we stop it getting worse? How do we stop further damage to the valve of the heart or the heart itself, which can require surgery? So that's good care, regular follow-up, take your antibiotic prophylaxis regularly, and make sure you're keeping an eye on your general health status. So there's things right across the continuum we can do to prevent rheumatic heart disease.
She might need another operation when she's older, but at the moment she's doing really good. It took me 3 doctors, and I don't know if the first one would have knew, maybe she wouldn't have to have an operation, and maybe they would have caught it early and just given needles.
Whether you are working in Adelaide or in remote South Australia,
Okay.
you need to know what
As I
to do if
have
someone
stopped
presents
this in the
with
past, you
fever
can finish
or rheumatic
watching
heart
it.
disease.
But this video shows you that rheumatic heart disease and the dangers of rheumatic heart disease, what it can do to the heart and the valves. And we're going to talk about those things. Now, when we talk about rheumatic heart disease, we're talking about the movement of blood through heart valves, through the heart chambers, and things like that. But we're going to start with rheumatic heart disease. And I think this video is a good introduction to what I want you to learn. So at the moment, we're going to look here at this slide. So when we look at rheumatic heart disease, McHargue, get it together. We're talking about the organism, the bacteria of group A beta hemolytic streptococcus. And that is what causes strep throat and can cause other things, infections in the body, bacteria growth. And it is what attacks the mitral valve. And with the strep throat, as in this video, they talked about treating the recurring infections with antibiotics. The one pick of antibiotic that they recommend is penicillin, but unlike some people, I'm allergic to penicillin, so it would be a different antibiotic. So rheumatic fever is caused when strep throat's not treated, and it reoccurs and reoccurs and reoccurs and causes an inflammatory disease that develops when strep throat, also known rheumatic fever, a scarlet fever, that develops in the body. And again, as they said, is not properly treated. Now, this point here, the mitral and the aortic valves are the two valves that can be damaged by this disease process. So you'll hear me speak more on the mitral valve and some pictures on the mitral valve, but remember that it's aortic and mitral valves that are damaged by rheumatic heart disease, leading to stenosis. Rheumatic heart disease is caused by this fever, this organism of bacteria, which occurs most often in school-aged children. Think about our kids. Our younger kids, they love to hug, they love to be around other folks. Now, COVID's changed all that, but let's talk when COVID wasn't around. They share things, the brothers and sisters or siblings, however you want to put it. They're in a house together, so strep throat can go through a house pretty quickly, especially if tonsils are still in place. But this organism may develop with an episode of this group A beta hemolytic streptococcus and cause pharyngeal inflammation. And then it scars as it goes through the bloodstream and gets back to the heart, to the valves, the mitral aortic valve. This organism attaches to those valves and causes scarring. It's simply treated and prevented with hand hygiene and mouth care, treated with penicillin. You're diagnosed with a culture swab. You're either strep positive or strep negative. And then you're nursing again. These are many opportunities, and I'm trying not to get into those too quickly. Teaching folks education, mouth hygiene, completing your rounds of antibiotics, going to the doctor when you need to. Some folks don't want to. Signs and symptoms of strep throat. Let's talk about that. So a high fever, 101 to 104. Fever and chills go together in this circumstance. Sore throat is sudden onset, which may cause severe pain and difficulty swallowing. So we get behind the 8 ball with dehydration, diffuse redness of the throat, and within the 24 hours, the exudate, those in the back pus of the throat. Petechiae begins to develop in the roof of the mouth if goes untreated, and large lymph nodes that are tender in the neck under the jawline, because that's where lymph nodes drain. Then we get into sinusitis and acute otitis media. That's earaches. And then if left untreated and doesn't go away, then there's a sandpaper-like rash, and that sandpaper-like rash comes along with the scarlet fever, hence the name scarlet. So throat cultures, accurate diagnosis, and adhering to antibiotics, nursing. Chronic heart valve damage can occur with this bacteria with any one episode of strep throat. If it's not treated, it doesn't go away. Inflammatory process affects the myocardium, that's the heart muscle itself, the pericardium, and the endocardium. Ms. Doig is going to take you through all those layers of the heart, and usually results in the distortion of scarring of the valves. The valves damage can lead to heart failure because the heart can't pump the way it needs to pump. So when we get into heart failure, we have malaise, shortness of breath. We can have murmurs and things like that. I'm not expecting you to know murmurs because at this point we're learning rheumatic heart disease, and we'll learn where we can find these heart sounds and these where the valves are. So we're looking at the next picture. Picturing rheumatic heart disease. This is a beautiful valve, and mitral valve it is, anterior posterior cusp. You can see the annulus being the darkest circular ring around that mitral valve. So strep throat develops, rheumatic fever develops if strep throat goes untreated, undiagnosed, and then you end up with rheumatic heart disease. And just in the video, you heard the gentleman speak of populations of folks that don't get to the physician, or populations of people that don't have the medical care that they can reach out to. And sometimes just in general, the poorer populations that don't go to the doctor. So what's nursing going to do? Diagnosing it. We've talked a little bit about rheumatic heart disease diagnosis, a thorough history and physical, assessing the symptoms of the patient, what they're experiencing at the time. So we talked about sore throat, fever, chills, pain, swelling of lymph nodes and things like that, recent strep infections, just one, that's all it takes sometimes, lymph node involvement, joint pain and inflammation. If you listen to the video, you'll hear the mom speak of their daughter. At some point in time, her hip joints were bothering her and she had trouble getting up and moving. And then some days she could get up and play and everything was great. Nursing is going to look at CBC. The physician or the healthcare provider is going to order that. So we would expect to see an elevated white count. We would look at the RBCs on that CBC to make sure that we're not already in an anemic state of inflammation. So the next test that you see here is CRP and ESR. And I'm going to ask you, what do you expect to see here? In your thought process, you should say those should be elevated. So they tell us the amount of inflammation in the body. An echocardiogram will be able to look at the valves. We'll be able to see the valves are stenotic and the vegetation on the valves. That is a very interesting picture to see, or a video to see, that I'm sure they have plenty on YouTube. But when you see vegetation on valves, it is like fingers that float as the blood goes. And those are not supposed to be there. The valve is to open and close, the leaflet open, close, and no fingers flying away. So measuring on the echo, the size of the heart, the shape of the valves, and everything else that we can see, not just one, but all. And then we can see and measure pressure in the left ventricle. Chest x-rays will show the size of the heart. You heard the mom say she saw the heart on the chest x-ray and she knew that wasn't right. That wasn't normal, because a child's heart should not be that big. Some folks will have to have a cardiac cath just to check the pressures inside the heart. So nursing care, vital signs, eyes and nose. What goes in, you've heard me say this, must come out. So with a sore throat, it's hard to get kids and teenagers to eat and drink. So we got to push those fluids or they end up with an IV. We're looking for temps 101 to 104. We're going to look hemodynamically monitoring. When we do the heart casts or we do the echoes, we can tell pressures inside the heart, assessing the heart for sounds or extra sounds, and also assessing the lungs to making sure that we're getting oxygenated and hydration. Then we're looking at medications, and the medication of choice is penicillin to treat the strep, and there are other antibiotics for those who cannot tolerate penicillin. Long-term antibiotics for these folks, especially before dental procedures, because if this bacteria is released in the bloodstream, it can go right to them heart valves. So some folks that have a floppy heart because of this rheumatic heart disease, we end up having to give them some lanoxin or digoxin to make that contractility better, or we end up having to also either or diuretics so that we can help with getting rid of fluid that they can't get rid of. So rest, quiet environment. So some people will tell you that when they're sick, they don't want anybody bothering them and they need to rest. That's a good place to be sometimes. Sleep, you know, teenagers, if you have teenagers or ever been around a teenager, some of you are young enough to still be teenagers or not far from being a teenager, you need your sleep. The body heals best at rest. So let's talk about heart valves. So what I want you to remember with heart valves is that blood should move forward through the heart. And as we look at this heart, we're going to see some valves. There are 4 valves. First one mentioned is between the right atrium and the right ventricle. Yes, you need to know where these heart valves are. Tricuspid valve is here. Tri meaning there are 3 cusps to the leaflets of this valve. And then we move from the right ventricle out the pulmonary valve. And where does that go? To the lungs, because all this blood's coming in right here on the right side of the body systemically. And then we're going to the lungs to pick up oxygen. Then we're coming back into the left side of the heart, the left atrium. So we're going to look here and we're going to see this mitral valve that is between the left atrium and the left ventricle. Important valve to remember. This one, as you see over here, that it has 2 leaflets on it. Important to remember because when we talk about different issues with heart valves, we'll know why that disease process does what it does. And then the tricuspid valve, there's the 3. Then we have between the left ventricle and this beautiful aorta, an aortic valve. So when we talk about heart valves, and I'm going to give you hints here in just a little bit on the direction of flow and what we should be looking for. This is all in your med-surg book, chapter 28. So remember that blood should move which way? Forward. How many valves do I have? 4. I have 2 types of AV valve. What does AV mean, Ms. McHargue? AV means atrial ventricle. So in between the atria and ventricle are 2 valves. We have the tricuspid and we have the mitral. Tricuspid between the right atrium and the right ventricle. This is our anatomy review. And then the mitral is between the left atrium and the left ventricle. Tricuspid has 3 leaflets, mitral has 2. Then we have the semilunar valves located between the ventricles, going out to their corresponding arteries or perspective designated areas. Pulmonic valve names itself, it goes to the pulmonary system. And then we have the aortic valve that leaves the heart and goes to the rest of the body. So 4 heart valves, just said them, need to know where they go, where they come from. With forward flow of blood pressure, valves will open. So as the blood pushes through the heart systole, it's going to open these valves. With the backward flow of blood and pressure, the valves will close diastole. Valves are anchored to the heart by the annulus ring. Saw a picture of that just a little bit ago when we looked at that one mitral valve picture, but you can almost see it here on this mitral valve. Annulus ring is going to be important because that's what keeps those valves in place. And they are also attached to that area with chordae tendineae, muscles and tendons that help open and close and constrict and relax. When the ventricles contract, there is an increase in ventricular pressure, closure of the AV valves, mitral and tricuspid, opening the semilunar valves, aortic and pulmonic, and systole. So in ventricular contraction, increase in pressure, closure of AV valves, mitral and tricuspid, open of semilunar, aortic, and pulmonic during systole. So yes, the opposite in diastole. The atria will contract and squeeze, increasing atrial pressure, opening up the AV valves, mitral and tricuspid, and closing the semilunar valves, the aortic and pulmonic in diastole. Ms. Kofke talked to you about all of those words, systole, diastole, just recently here in Unit 1. But this is Unit 2, so we're moving forward with the knowledge that we have. So again, as we discuss valves, we need to remember blood flows forward, and that we need to know where the blood is going, from what chamber to the next, and what valve it crosses in the process. Now, the reason I say that is from the right atrium to the right ventricle, we cross across the tricuspid valve. I'm sure there's a mnemonic somebody has or a saying that goes, but this one I wanted to share tissue paper, my assets. Tricuspid valve is first. We see it there. And then if I go across out of the heart into the pulmonary system, paper, pulmonic. Then I come back, left atrium, across to the left ventricle and the mitral. And this is a trouble spot where valves get in trouble. They can get in trouble anywhere, but this is a hot spot. Assets being aorta or aortic valve going out of the body from the left ventricle. So when we talk about stenosis and regurgitation, remember where your valves are, where the blood is leaving, and where is it going to, because that's going to help you understand what's going to happen in that chamber of leaving and going. So remember, this is the order of how blood flows and from which chamber, going across which valve, in the direction forward. Next slide says valvular disease, causes and risk. Again, when we talk about heart valves, sometimes they open and close the way they need to. Sometimes they don't. So this is where we get into disease processes. So valvular disorders occur in children and adolescents from congenital conditions. They're born that way, or they develop that way, or the chromosomes make them that way. In adults, a degenerative heart disease from multiple factors we'll discuss as we go. And then the risk factors for valve disease in kids, adolescents, and teens is this rheumatic heart disease we just talked about. Adults, we talk about MIs, atherosclerotic changes, we age, things change. So just remember ages and disease process. Valvular heart disease pathophysiology. So when we talk about pathophysiology, blood volume and pressures, there's lots of volume that hangs out in each chamber during systole and diastole. And where does it go? Pressures will adjust in systole and diastole. So blood volumes and pressures are blank in front of the affected valve and blank behind the affected valve. So let's talk about the abnormalities: stenosis, regurgitation, also known as insufficiency, and prolapse, and that may help you understand what goes in the blanks. And yes, I'm going to tell you. So when we have regurgitation, and stenosis. Let's talk about regurgitation first. As I said, also known as insufficiency. Blood is going to move backwards, regurg, retrograde. You'll hear that word used as well. So regurgitation is when the valves do not close completely. Blood flows backward, retrogradely through the valve back into the chamber where it came from. Remember, I said that's going to be important to remember. It's going to help you just with the disease process. Stenosis, you will hear the word stenotic, is when the valves do not open completely. And these valves are constricted, narrowed, and have a tiny opening. So we're trying to force a lot of volume out that stenotic valve. So the saying and the blanks up here, so blood volume and pressures are reduced in front of the affected valve and increased behind the affected valve. So if I have a stenotic valve and I'm trying to push a volume through that stenotic valve, then the pressures are going to be higher. Vice versa, regurgitation. I do have some videos that I've attached that are going to be important for you to watch. That would help if you understand. So let's talk about mitral valve again. Mitral valve can prolapse back into the left atrium during systole, causing the leaflets to billow and stretch. Billow means to stretch long back into the atrium during that time, systole. So in prolapse, mitral valve leaflets billow, stretch long back into the atrium during systole. So how do I know and how can I tell if there's something wrong with these valves? So for the last year and a half, you've learned Erb's point. Important to remember where these spots are and where to listen to the cardiac sounds. All people enjoy Time magazine. I haven't seen a Time magazine in years. So there's 5 areas to listen in the heart, and let's talk about them. So you've learned Erb's point. Oh boy. You've learned Erb's point from the beginning, and you know now that when you listen to a heart, the valves open and close and cause the S1, S2 sound, the lub-dub sound. So when you hear lub-dub, listen to the heart. The spot to put your stethoscope is right here. The left side of the sternum, 3rd intercostal space. Now let me explain intercostal for those of you that may not know or remember. See the rib bones. So in between the rib bones is the intercostal space. So listen between the bones, not on the bones. And if you're listening between the bones, you can hear better. Erb's point, know where that's at. So if we want to hear abnormalities or we want to hear what's normal in the aortic valve, we can put our stethoscope on the right side of the chest at the 2nd intercostal space, and we can hear the aortic valve open and close. Remember, intercostal space, 2nd right intercostal. Aortic valve comes first. So then we move over to the left side to listen to the pulmonic valve, and it is the 2nd intercostal space, and we can hear that lub-dub sound again, but it is the pulmonic valve that's opening and closing. Now we're going to move down to tricuspid. So tricuspid is going to be right here at the lower left, on the left side of the sternal border at the 4th intercostal space. So when I'm listening, I'm going to slide off the sternal border into that 4th intercostal space, and I'm going to listen to the tricuspid valve open and close. Lub-dub, lub-dub, lub-dub. If I hear anything different, then we know we got something going on. You got to know normal. I've always said before you can pick up abnormal. So let's move down to mitral valve. So it is the 5th intercostal space, It is dividing the clavicle mid-clavicular, sliding down intercostal, and listening right there, mitral space. Left fifth intercostal. You see the word medial, but it's in the midline of the clavicle. Slide down fifth intercostal space, mitral. Aortic, pulmonic, tricuspid, mitral. Second right, second left, pulmonic, tricuspid, left fourth, mitral, left fifth, mid-clavicular line. So those are going to be important to remember. Why do I need to know? Because you need to know when you listen for these heart valve sounds. When we talk about stenotic, different aortic stenosis, regurg, mitral stenosis and regurg, where can you go to find out if we got some issues or problems going on? Stenosis and regurgitation. We talked about what stenosis and regurgitation was. Stenotic stenosis means constriction or narrowing of the valve. And these valves do not open completely. They're tight. And regurgitation means a backward flow of blood through the valve, and they do not close completely. So when we're talking about these stenosis and regurg and these spots we're going to listen to, it's kind of like a C shape around that cardiac area, Erb's point. Where are we going to auscultate? Where are we going to pick up the spots? Which direction is the blood going? It's meant to flow forward. And how does it affect the heart or the body if it doesn't get to where it needs to go in its forward direction? Those are three questions that I think in my head when I'm listening in the specific spots. So we talked about stenosis, we talked about regurgitation, we've talked about prolapse. So when we talk about aortic valve stenosis, we want to listen in the aortic valve spot. Second, right side intercostal space. Blood flow becomes restricted because it's stenotic from the left ventricle going out through the aorta, resulting in what goes in that blank is left ventricular hypertrophy or left ventricular dilation. The aortic valve narrows, causing the blood a difficult time to get out of the left ventricle. So left ventricular hypertrophy goes in that blank. Causes of aortic valve stenosis is congenital because the leaflets are not formed the way that they need to be formed. It can be caused by rheumatic heart disease. In adults, it can also be caused by a degenerative calcification of atherosclerosis, diabetes, inflammation, hypertension, lipids, triglycerides, and smoking. Symptoms, you're going to see these folks develop symptoms gradually. Patients have exertional dyspnea. That means if I'm walking, I'm working, I'm trying to exercise, then exertionally, I'm getting short of breath. That's because blood is backing up. Where? If I can't get out of the left side of the heart, where's the blood coming from to the left side of the heart? Back to the heart, the left side, from the lungs, right? So I'm going to back up fluid and blood into my left side of the lungs. Angina, chest pain due to increased oxygen demand. My left ventricle is really working hard because it's trying to push blood out that aortic valve. It's not going anywhere. So I'm having chest pain. Systolic pressures are low, narrowed pulse pressures. My heart rate can be slower. And then my pulses and my extremities can be lower. Because you think about that blood not getting through the aortic valve out to the rest of the body, then I don't have anything that's pushing it out. It's trying, the left ventricle is, but it's not getting there because that aortic valve is squeezing shut. Let's see. faint pulses, fatigue, I'm tired, I'm short of breath, and then exercise intolerance, syncope, and heart failure. We mentioned that the blood backs up in the lungs because that's where the blood comes to the left side of the heart. So we get into heart failure issues. Now, if I hear and I listen on the aortic valve spot, where is that spot? Right side, second intercostal space. I can hear an extra heart sound if you listen closely. As I've said earlier, when you listen to heart sounds, sometimes when the lung sounds are so bad, you really have to close your eyes and concentrate on that lub dub, lub dub, lub dub. But you will hear extra heart sounds when you're listening in the aortic spot when you have stenosis. We're going to monitor our patients hemodynamically by the echo. We're going to look in those valves. Diagnostically, we're going to be doing a cardiac MRI, and we are going to be doing the echo, as I just said, and some folks will have a heart cath so we can see the pressures inside the heart. We want to teach our clients to avoid stress tests. Why? Because if I push you really hard on the stress test to see where your blood pressure goes and your heart rate goes, then that could possibly cause you to go into VFib or VTAC. Not good. So avoiding stress tests for these folks and avoiding competitive sports and avoiding strenuous activities because of myocardium is having a hard time working. So here, treatment is controlling the risk factors. We're controlling diabetes, we're controlling lipids, we're controlling hypertension, and we're controlling smoking. Lots of good areas for nursing care and those things, because you need to educate these folks. And when I say educate, people are going to hang to your word of what you say when you teach them. If you are teaching a client about their diabetes and being compliant with meds, they're going to say, well, that nurse said, this is what I need to do. Or that doctor said, because you're going to reiterate what the doctor said. So when these folks are also nursing care education is dietary needs. So what do we need to do dietary? Low sodium, low cholesterol, that cardiac prudent diet. We've got to control the salt, sodium. Nitroglycerin is contraindicated with these folks. Why is that? Because it reduces preload. You open them up, vasodilate, and you also dilate their arteries. So you're reducing their preload. And if you give them nitroglycerin, they're going to get hypotensive, blood pressure drop very quickly. Prevention is preventing rheumatic heart disease, controlling the risk factors. We just talked about those. Diabetes, hypertension, cholesterol, triglycerides, smoking. So lots of things for nursing to do. We're going to teach them about preventing infections, bacterial infections, going to the doctor to be seen when you are sick and running a fever of 101 to 104. You're going to assess their heart, their lungs, their pulses. You're going to ask them about shortness of breath, orthopnea. What is paroxysmal nocturnal dyspnea? That one is one that you will see mentioned a lot when we talk about these heart valves, because paroxysmal nocturnal dyspnea is that shortness of breath during sleep at night as you're laying down or during the day. But when you're sleeping, your body wakes you up gasping for air. We're going to get them on the correct medications. For the symptoms that they are having, we're going to teach them about daily weights, and the physician will let them know, cardiology, American Cardiology or the American Heart Association, both will tell you to teach your client that in a day, if you've gained more than 3 pounds, you need to let somebody know, or within a week, if you've gained more than 5 pounds. So I know some of you may say, well, Ms. McHargue, I may gain that much weight. Fluid for whatever reason. But if you have stenotic valves, you need to be talking to your provider and documenting your weights daily. There's a video right here about aortic valve problems. Good to watch. Not there for just to ignore, but I need you to watch these videos. So here we look at the normal heart. We see the aorta here, nice, beautiful and red. And right here, we see the aortic valves coming out of the left ventricle, going across the aortic valve, out the body by the aorta to deliver oxygenated blood. Here, normal aortic valves, we have open, looks great, and then it closes. This is the way it's supposed to be. So when we see abnormalities, they don't open all the way and they don't close all the way, leaving that tight, narrow area for blood to get out of the left ventricle. What happens to this left ventricle because it's working so hard? Remember that word, hypertrophy. It gets bigger, gets dilated. So aortic valve again, but this time we're going to talk about regurgitation, that retrograde backwards flow from the aorta back to the left ventricle during diastole results in left ventricular dilation and also left ventricular hypertrophy. Why is it the same in both? Well, we're going to talk about that. So regurg is going backwards between the aorta and the left ventricle. Blood's backing up into the left ventricle during diastole. So I have a larger amount of volume in there than what I should have. So again, regurgitation and insufficiency are interchangeable. So you will hear it called aortic insufficiency as well as aortic regurgitation. And this is happening because of that valve leaflets are not closing all the way, they're staying open. So what causes this? Inflammatory lesions, rheumatic heart disease, leaflets of the valves are damaged, dilation of the aorta when it's growing from all the high pressure, congenital abnormalities. We don't have the number of leaflets on the valve that we're supposed to. Infections such as syphilis and deterioration of a surgically replaced aortic valve. Yes, sometimes they can replace things and still we get into trouble because people don't take care, they're non-compliant with their hypertension. There's a video, yes, at the bottom of the screen. So in the line at the top, retrograde blood flow from the aorta into the left ventricle during diastole results in left ventricular dilation and also left ventricular hypertrophy. So signs and symptoms for these folks, what are you going to see them look like? They're going to be short of breath, have a hard time breathing when they're laying down, orthopnea, dyspnea on exertion. They're going to have that paroxysmal nocturnal dyspnea, shortness of breath during sleep. They're going to have murmur over that aortic area. We talked about where that's at. And then these folks, this video is interesting because it shows this thing that I'm fixing to talk about, the pulsating push from the ventricle to try to get out the aortic valve. And it's very forceful. So these folks are going to say they feel this pulse in the side of their neck that's like a hard push. And that ventricle is working really hard to do what it needs to do. So watch that video. Now, when I looked at this information, I saw calcium channel blockers, diltiazem, and verapamil are contraindicated because, well, your book says these folks need to be treated with calcium channel blockers. Well, that's a discrepancy in my book, but calcium channel blockers are broken up into 3 groups according to their chemical structure. So yes, the information that you see on this slide that says calcium channel blockers, diltiazem, cardiazem, and verapamil, also known as CALAN, C-A-L-A-N, are contraindicated because if you give a client either one of those medications to treat the aortic valve regurgitation, you can put them in trouble. You can cause them to become bradycardic from the verapamil and the cardiazem, and you can also drop their blood pressure from the cardiazem, diltiazem, and then you make them lose their ventricular contractility because you're taking away what that pump needs to do. What you're going to treat them with is calcium channel blockers, and those calcium channel blockers that you're going to treat them with are felodipine, F-E-L-O-D-I-P-I-N-E, nifedipine, N-I-F-E-D-I-P-I-N-E, and then you're also going to treat them with ACE inhibitors, the captopril, enalapril, and lisinopril. Captopril, enalapril, or lisinopril, any one of the three, cardiologists will decide, because we want to provide them some afterload reduction. So we talked about diagnostics being echocardiogram again. And we talked about treatment. I just went over those. Aortic valve replacement, if need be, and the patient becomes very symptomatic with their regurgitation. Valvuloplasty, going to the cath lab and having that valve opened up. Then for folks that are very, very symptomatic and are watched, and we know they become symptomatic, they will go have that valve replaced. So again, avoid physical exertion and competitive sports with this condition as well on this aortic valve, both with stenosis and with regurgitation. Patients with aortic regurgitation and hypertension should be on that felodipine, calcium channel blocker, or nifedipine, and an ACE inhibitor as well, the both of them. Lots of areas for education in this aortic valve regurgitation, and education is that low sodium diet, the side effects of the medications, because some people that take medications, they don't like the way they feel, they stop taking them. We got to watch their eyes and nose. We have to assess their heart. We have to have a baseline to determine how and if the disease process is changing or worsening. Daily weights in the morning, each day, the same time. So remember, our medications that we don't want to give these folks is the calcium channel blockers of diltiazem or verapamil. We don't want to give them, but we can give them the other class of medications, the dihydropyridines of calcium channel blockers, dihydropyridines, DIHYDROPYRIDINES. 3 classes of calcium channel blockers, and these folks can have that class. Okay, so let's move forward to see another picture of an aortic valve regurgitation. And here I see where this valve is not completely closing, and I'm seeing blood back up into my left ventricle. On the echocardiogram, I'm seeing blood backing up into my left ventricle. Characteristics. Remember I told you that big push pulse they feel in their carotid or in their neck. It's called a water hammer pulse. A jerky pulse that is full and then collapses because aortic insufficiency. Some of the blood is coming through, but then sometimes it is not. When the blood is ejected into the aorta, it regurgitates back to where? The left ventricle. It is also called Corrigan pulse or collapsing trip hammer pulse. I'm fixing to show you a video because I want you to see this. And this way I know that we watched it. You gotta love YouTube. Look at that pulse. It's dancing. Aortic sufficiency, aortic valve regurgitation. There it is. It's listed on here for you to watch. A good place to watch it. And then let's look at this picture. Because here, come on. This one, I'm going to tell you, when you look at it, you're going to go, wow. And I'm going to move on. It is in the back of the throat when you're looking at the tonsils. You have to see it. Aortic valve regurgitation. Let's review. Where do we listen to the aortic valve? In your mind, you should say, I know we're not in the classroom, but in your mind, you should say, Ms. McHargue, aortic valve is the right side, second intercostal space. I'm going to listen for lub dub. If I hear anything other than that, then I know something's going on that's not supposed to be. It's aortic valve regurgitation. Clinical manifestations are acute. They happen quickly. They're sudden. Cardiovascular collapse can happen because I don't know that I have this disease and I'm out on the basketball court and boom, fall over dead. And then I end up with, or another patient left ventricular exposed to the aortic pressures during diastole and causing my left ventricular hypertrophy. I'm weak, short of breath, severely dyspneic. I have chest pain because my heart's working too hard. And I'm hypotensive already, so I don't want those particular type of calcium channel blockers I talked about, which all of this, if we get into trouble, constitutes a medical emergency. You saw how fast and how pushy that was in that picture, but you're going to be saying, wow, when you look at that throat. So let's talk about some mitral valve issues. Let's talk about mitral valve prolapse. Before we go there, we're going to talk about mitral valve stenosis. Where am I going to listen to that mitral valve? You should look at your picture. When you memorize these places, it's going to be on the left side. It's going to be the fifth intercostal space, mid-clavicular line, mitral valve. So mitral valve stenosis, I have a stenotic valve. It's tight. It's not letting blood go through the way it needs to. Where is the mitral valve? Between the left atrium and the left ventricle. And there, because it's stenosis, there's an obstruction there. Don't look at your MVP. I'm talking mitral valve stenosis. So what I'm going to do is I'm going to stop sharing because I want you to hear what I say. Mitral valve stenosis. This is when there is an obstruction of blood from the left atrium to the left ventricle. Blood is backing up into the lungs. So what kind of symptoms is my patient going to present with? Shortness of breath, pulmonary congestions, that paroxysmal nocturnal dyspnea, orthopnea. We're going to see the left atrium enlarge. We're going to see the left ventricle enlarge. And when we listen over that mitral valve spot, I pause so you can think about where is that mitral valve spot, left side, fifth intercostal space, mid-clavicular line, we're going to hear something we're not supposed to hear. That's not a lub-dub sound. It'll be a lub-dub swish, lub-dub swish, a murmur, okay? So that's mitral valve stenosis, obstructed area between the left atrium and left ventricle. Blood's backing up to the lungs. Mitral valve regurg. What is regurgitation? Get this in your brain. Regurgitation means that I have retrograde blood flow backing up. Where am I backing up? From the left ventricle to the left atrium during systole. When my left ventricle contracts, no, that's not supposed to happen, because the left ventricle out the aorta and the regurgitation of the mitral valve, that blood, when left ventricle squeezes, it's backing up into the left atrium as well as where it's supposed to go, out the aortic valve. Mitral valve regurg. Let's do that one more time. Where is the mitral valve? Left atrium to the left ventricle. What is regurgitation? It is retrograde blood flow, backing up. Normally, your left ventricle is going to pump blood out your aortic valve, out your aorta. Now, in mitral valve regurgitation, that doesn't happen all the way. Something happens differently. Regurgitation causes that left ventricular to squeeze and systole, and some blood's going to the left atrium. It's backing up. Where does it go? Where does blood come into the left atrium? But the lungs. So blood's backing up to the lungs. So in regurgitation, the valves do not close completely. Remember that, causing the blood to backflow. These folks may be a little asymptomatic at first, but as time passes, they're going to have signs and symptoms or symptoms of heart failure, dyspnea, fatigue, weakness, dyspnea on exertion. These folks may have a cough because I may have fluid in my lungs. All right, where do I go next? Back to sharing. Those were mitral valve stenosis and mitral valve regurgitation. You may have to listen to that a couple of times to get it under your belt. So going back to my beautiful pictures. Mitral valve prolapse. Now earlier we said prolapse was that when the mitral valve doesn't open or close the way it needs to do, the leaflets of that mitral valve billow back, stretch back into the left atrium, right? Yes, Ms. McHargue, that's right. I'm pulling my papers back up, so make sure that I tell you correctly. Valve billows back, I just told you the answer, into where? What happens? Why does this happen? It is an inherited connective tissue disorder resulting in enlargement of one or both of the mitral valve leaflets. So remember I said mitral valve has two leaflets, anterior and posterior. And when those don't work the way they need to do, they prolapse. What holds those leaflets in place? The chordae tendineae attached to the papillary muscle of the heart wall. So as they billow back, sometimes those chordae tendineae have a tendency to stretch so far, then they pop, allowing more of that valve to go back into the left atrium. Structural damage. When you listen over the mitral valve area, pausing so you'll remember where the mitral valve area, left, fifth, mid-clavicular, intercostal space, you're going to hear a click. You're going to hear that click because the leaflets are backing up, prolapsing back into the left atrium. It's more common in women. We said that the cause of this is inherited connective tissue disorder causing enlargement of one or both of the leaflets on the mitral valve. Symptoms in the beginning are asymptomatic, but later, as time goes on and the heart gets tired, we get fatigued, short of breath, lightheaded, dizzy, syncope, palpitations, chest pain, or anxiety. Now, I can relate some of those symptoms to each other. I'm going to repeat them one more time. Fatigue, short of breath. I'm fatigued because I'm short of breath. I'm lightheaded because the blood's not getting to where it needs to be. I'm dizzy because I'm short of breath and I'm anxious. Syncopal, I pass out because of my fatigue and anxiety. Palpitations because I have blood backing up into a chamber it's not supposed to. And chest pain is because my heart's working hard. Sometimes women will come in with atypical chest pain anyways when they have chest pain, but with mitral valve, what am I going to do? I'm going to assess my heart. I'm going to listen to my heart sounds, and I'm going to hear lub dub, lub dub, lub dub, and then I'm going to lub dub, lub dub, lub dub. So you're going to hear a click sound. I'm trying to do it. Can't do it as good as some people can. So when this happens, you're going to see folks have atrial and ventricular dysrhythmias, atrial fib. What's the key to atrial fib and how am I going to treat it? Coumadin or anticoagulants, warfarin. We're going to look at this person diagnostically with an echo to diagnose and monitor for progression. What are we monitoring for progression? Sodium causes weight gain and weighing each day. What goes in will need to be monitored, and we need to monitor what comes out. We're going to treat them especially to control the symptoms for the atrial fib issues, making the heart run away, palpitations, they're feeling the atrial fib, my heart flying away. Need to teach them how to check their pulse. Chest pain, I need to get to the hospital if I'm having chest pain for no matter what reason. If I'm anxious, then I need to sit down and rest. If that anxiety doesn't go away, it could be because my pulse is tachy, because my atrial fib's heart rate's 120, 130, 140. Just telling you what to look for. If they're having these dysrhythmias, then we need to think about, are they taking their anti-dysrhythmic medications the way that they need to? I don't like the way it makes me feel, so I'm not taking it. Well, you can't do that. Here's something that some of you may say, oh, we're going to eliminate caffeine from their diet. Well, what does caffeine do to my diet? Causes my heart to race. Do I want the heart to race and mitral valve prolapse? I don't. Because caffeine increases our heart rate and makes our anxiety worse. Where is that mitral valve place to listen for? Another video for you to watch, but where is that mitral valve place? Gonna pause. I hear you thinking on the left side, 5th midclavicular, midline, intercostal space. Left, 5th, midclavicular, mitral. Repeat it, repeat it, repeat it. So if the clients for chest pain do not respond to nitroglycerin, do they need nitroglycerin? For chest pain, that's usually the first drug of choice. But if they don't respond and the chest pain doesn't go away, it's because of this mitral valve prolapse. They may need some calcium channel blockers or some beta blockers. These are not differentiated. That would be cardiologist's choice. And we're going to treat their heart failure. So they may need some diuretics. If they become too symptomatic, treatment-wise, is going to be replacing that mitral valve. Nursing needs to educate. And I say that over and over again. When you talk to someone and you're teaching someone, clients, patients, whomever, they're going to hold you to your word and they're going to listen to what you say. They may not do what you say, but they're going to hear what you say. Eliminating caffeine, eliminating alcohol. They're going to look at their over-the-counter medications to see if there's alcohol or caffeine, ephedrine, or other cold medicines that may have something in it that's going to increase my heart rate. They don't need it. There are medications out there that don't do that. So they also need to watch their diet, low sodium, low fat, low triglycerides. They need to stop smoking. They need to take their full round of antibiotics. And these folks will need to take antibiotics before dental work because we don't need that bacteria attacking this mitral valve. Follow-up appointments are very important with any cardiac patient, in my book with any patient, but really with any cardiac patient because they need to see the cardiologist because the cardiologist needs to know if their condition is worsening because treatment may change. And they need to be honest about their symptoms, educate them on their diagnosis, what's going on, what the prognosis is, and there's treatment out there. And we need to educate these folks on sleep, activity, and resting. So in this video, it describes the disease process of mitral valve prolapse. I'm going to make this part talking about valves and valve disease, 2 parts. So be looking for a second video. I'm going to move forward just a little bit. There's a beautiful picture of a mitral valve. So we see that the leaflets on the mitral valve, we know that there's 2. They're not really looking that good. Some of them have been turned loose. It's not a beautiful picture. This should be one whole picture. Ms. Kalki, I need to learn how to work. Oh, looky there. This valve should be 1 part anterior and should be a lower part called the posterior. Now I need to learn how to work it if I'm going to use it. So anterior should be 1 piece and posterior should be 1 piece. So something's happened here. So we see the annulus go around in the circle. This is the part that holds that valve in place. And anatomy and physiology will hold you. Normal mitral valve, 2 leaflets, I just drew them. Blood flow is going to go through them. Chordae tendineae attached to the papillary muscle. When it turns it loose or the papillary chordae tendineae break off, it's going to allow this mitral valve to prolapse, to billow back. Blood flow has trouble getting to where it needs to go, to where it's supposed to go. Blood ventricle. Here we are. That's where all my chordae tendineae sit, holding on to that mitral valve. Okay. Valvular disease. We talked about diagnosing them. We've talked about where they are. Ooh-wee. I got to get rid of that. So I'm going to stop here. I'm going to come back to this point, part 1, part 2.